Sir, can we start, sir?
Yes, you start immediately.
Bismillahirrahmanirrahim. Good afternoon to everybody. Welcome you all to our weekly session of Oncology Club. Today we are going to start a new series, and we have named this Real Life Case Discussion. And today we are going to start with breast cancer series. Today we are talking on DCIS. I will have four faculties with me. Dr. John Conybeer, who is a clinical oncologist from Barth NHS Trust Hospital, UK. Dr. S.K. Farid Ahmed, who is oncoplastic surgeon working in Wickham Hospital, UK. And as a local faculty, we will have Dr. Arman Reza Choudhury, who is a consultant of radiation oncology in Evercare Hospital, and Dr. Abdullah Al Mamun Khan, who is an assistant professor in the Department of Medical Oncology in Shohid Sohrawardi Medical College, Dhaka. So all four of them will be with me in the session. And as per custom, we want to start with a few words from our president and patron, Professor Amy Heiser. So, sir, if you please formally start, then we will go to the session. Professor Amy Heiser, who is the president of our organization.
Okay, Bismillahirrahmanirrahim. Heartiest welcome to all of you, all the participants, faculties, John and Farid with us from England, and Arman Reza Choudhury and from Dhaka. Without any delay, I think we should start immediately.
Thank you, sir. So this is a new format. The program will be 60 minutes. It is a case-based discussion, so there will be no presentation. The sequence will be, I will be talking with the local faculties first, then overseas faculty will supplement. We'll be talking mainly all the practical issues faced by clinician. And in every step, we will put an opinion poll so that all the participants join in the poll to get their view. There is no right and wrong answer. The poll will be that what you feel. And we will be identifying the best performer in the poll respondent. And the next week, we will give the award to the best performer. So this is the housekeeping rule. So let me start with the case. It's a very classical case of 40 years old lady, hypotensive, para 1, small lump in upper outer quadrant of the right breast. And she was done a core biopsy, and it was proved as a DCIS, 1 centimeter size, 3 millimeter margin, grade 3, ER positive. I mean, all this formation was there. And there was no axillary lymphadenopathy. So the first question, Shorna, I want you to bring to all the question that please put the first question. So we'll be there for 30 seconds. That what imaging is indicated for DCIS that you think is correct. There are 5 options. You have freedom to choose any one. And I am telling again, no one is right, no one is wrong. Is what you practice that is important. So we have 25 participants, still now only 2 joined. Shorna, I think we can give some more time. Keep for 1 minute. So 7 out of 27. Please, I want more time because so the majority join. I want maximum to join. Please try to respond, whatever you feel. Just to see how we define ourselves.
The poll is already completed.
Okay, I think 12 out, only 44% joined. So if you look at 1 out of these 12 said bilateral mammogram, none was in favor of ultrasonogram, 1 was in favor of MRI, 2 was bilateral mammogram with MRI in select case, and 67% were ultrasonogram and mammogram of both axilla. So this is the, so you stop the poll question. So now my question is to Arman. In your practice, what you do, what imaging you use.
Okay, thank you, Dr. F.M. Kamaluddin, sir, for your question. Actually, because the diagnosis is done that it is a DCIS, ductal carcinoma in situ. So in my practice, I would go for bilateral mammography, as well as the option of MRI is in selected cases already mentioned in answer 4, that is bilateral mammogram with MRI in selective cases. This is my choice actually.
Mamun, do you want to agree with him or you want to differ?
Thank
If
you,
you
sir.
suspect this is a case of DCIS, not in this case, when he is a suspect or you know this is a DCIS.
Thank you, sir. I am.
Do you agree with him? If you disagree, tell me. Otherwise, you
I
say.
agree with Dr. Armando Chaudhary, and I have another option: the review of pathological flight or
We are talking about image. Mamun, we are talking about the image.
bilateral mammogram.
So bilateral mammogram.
Yeah.
So, but our majority answer was ultrasonogram and mammogram. So the mammogram is commonly used for screening. In our country, we don't use screening. And the discussion is for MRI. So there is a paper in Lancet. We have shown that MRI is sensitivity is 98% in DCIS. And the Annal of Surgical Oncology, again, they have shown that there may be overestimated of disease by MRI. And this is another paper, same journal in 2013. Again, they said that it may not reduce the re-excision rate by using MRI. A similar controversial conflicting paper on MRI was there. So now, John, what imaging you use for DCIS in your center? John. Okay, I think Farid.
Thank you, Kamal. Well, first of all, I just wanted to thank you all for inviting me to this program. Can I ask this question in a reverse way? Because we don't diagnose DCIS and then do investigations.
Yeah,
we do it other way.
Yeah,
The
so if you
patient-
suspected
someone
DCIS,
presents with a lump
yeah,
in the
suspect.
breast.
Yeah.
I would like to investigate with a mammogram and ultrasound breast and axilla to begin with. And if mammogram shows a spicular lesion or a solid lesion, not like microcalcification, even if the first core biopsy is benign, is DCIS, and if there is a high suspicion on mammogram that it could be an invasive cancer, then we would like to do a repeat core biopsy. And so just to say this answer, because patients presented with a lump, we would normally do a mammogram first, followed by ultrasonic scan of breast and axilla and a core biopsy. Thank you.
So for a suspected lump, I agree with you. We don't know what it is DCIS not, so it start with a lump. So lump you evaluate by mammogram and ultrasound. That is your common practice. But in which situation you prefer MRI? Or do you, let me make it focus.
If there is a discrepancy.
Do you do especially MRI?
Yeah, we do. We do. If it's a very young patients with DCIS or any cancer, so depending on patient's age, extensity, if there is a discrepancy between the size, clinically there is a lump, a large lump, and you see it on mammogram, a small area of calcification or a mass. So if there is a discrepancy between clinical and radiological things, then obviously we would also consider getting an MRI done. And the other thing, as I said, was if the patient is very young, we also like to get an MRI done for prior any surgical planning.
John, we were discussing about the imaging in the case of DCIS. As Farid rightly said, we are not supposed to know it is a DCIS at the beginning, so it is a lump in the breast. So he was telling that they start with the ultrasonogram and mammogram. Then if required in select case, they go for a young lady, they go for MRI. And we were showing some papers in case of DCIS, somewhere in favor of doing MRI, but some papers showed that MRI is not reducing the rate of re-excision. So there was a conflicting data of MRI. And we will share that in NCCN is telling that bilateral mammogram is fair for DCIS, in select case for MRI. But the challenge is, as Farid rightly said, we don't know it is a DCIS, so we need to take the help of your ultrasonogram and MRI, mammogram both. And in our country where we don't have this screening program, so mammogram, the highest role of mammogram for finding the macrocalcification, picking up DCIS is not there. But still, so in this situation, after all this discussion, would you like to make any comment on the imaging in this case?
Yeah, so in fact, I was trying to unmute myself earlier, but when the poll is up, I realized that you can't unmute. So I've also learned that today. So I was here. So I agree. So normally these patients will have come through for triple assessment. So they will have already had mammography and ultrasonography. And I agree with Fareed in so much as if there seems to be uncertainty or it doesn't seem to correlate the imaging modalities, then we'd normally do an MRI scan to corroborate the findings that we're seeing. So that's normally what we do in our center.
So we can summarize that even the guideline is telling that mammogram is the bilateral mammogram is the investigation for DCIS, but in a common practice to do a ultrasonography and mammogram both is a fair recommendation, and in select cases we can pick up MRI. So the next question to Mamun, would you recommend ERPR study for this patient? Yes or no?
Yes, sir.
You will do both the ERPR?
Yes, sir. Both of ERPR and in some cases where the tumor volume is 3 centimeter or more than 3 centimeter and pathology, if the pathology said that the highly proliferated, then I also request for HER2.
Okay, Mamun. So let us have the next poll. Mamun is in favor of doing ERPR. Shorna, give the next poll. It's very easy. Hormone test, we will do ER, PR, both none. Mamun was in favor of both. I didn't give chance to Arman. So let's see. So till now 58% is in favor of both. 60%, 30% is in favor of ER. So 100% answered. So Shorna, end the poll. So 27% is in favor of ER. Nobody is in favor of PR. Both is 60% and 9% none. So Shorna, can you stop the poll? Shorna, stop the poll.
Sir, already.
I think something is wrong. I cannot move it from the screen. Okay. So after this poll, Arman, it's up to you. Would you go for ER, PR? What will be your take? Which one you will do?
Actually, I will go for ear testing only.
Only ear.
Only ear testing. And regarding what Dr. Mamun is telling about the HER2 testing, so
we will be coming after that.
Okay.
We are going slowly. So for ER, PR, the great study was the NSABP 24, and where it have shown that there is a benefit by using tamoxifen. But if you look at the patient's distribution, you will see the 64% of the patients were ER, PR both positive, 13% were only ER positive, PR negative, 2% was ER negative, PR positive, and 21% was ER negative, PR negative. So only PR positive was 2%. That's why this recommendation is to do only ER. PR is not recommended in guideline, but many of us are doing ER, PR together. As I said, we are not telling anything right or wrong. Two paper, NSABP 24 and UKCCR, these two study was there, and there are still some questions. Shall we use endocrine therapy in DCIS? Here I come to John. What is your practice? DCIS ER positive. Are you giving tamoxifen to all?
We do discuss it now. It forms part of NICE guidance. So when I see my patients, I explain it's not in regards to survival benefit. It's about chemo prevention for contralateral breast cancers. And so the only ones that I don't is patients who've had bilateral mastectomies. So there's no benefit from chemo prevention in those circumstances.
What about AI? Do you use AI also or only tamoxifen?
So normally we're recommended to use tamoxifen, but some patients, if they've got, for instance, coagulopathy as a past medical history and they're postmenopausal, then I think considering an aromatase inhibitor is acceptable. But I think it then again comes down to a discussion about toxicity and benefit. So
how long, John, you give?
So normally 5 years, typically.
Okay. So Farid, anything you want to add, or it's okay with you?
John has rightly said everything. One thing is important to understand: if it's a mastectomy for DCIs, we don't need to recommend any hormone therapy. If a patient has had a breast-conserving surgery for DCIs, one has to discuss it. And if patient was supposed to get radiotherapy but didn't get it, then definitely hormone therapy has to be recommended. That's how NICE guidelines suggest. But if it's a young patient, personally speaking, with DCIs, I wouldn't mind after a breast-conserving surgery offering her hormone therapy. Tamoxifen for premenopausal women.
Okay,
Thank you.
So you see, this is the NSABP 35 paper, that what John was telling, that if you want, you can use AI also. Tamoxifen is the commonly used, but AI can be also used. And NCCN is telling that, as John said, that we can give, if it is ER positive, we can give tamoxifen, but it should be not more than 5 years. And aromatase inhibitor can be also used, but the discussion should be there that what is the benefit and what is the toxicity. So the next question is, ER is done, ER is positive. Next question, we always write ER, PR, HER2. Shorna, next question. Will you do ER, HER2 testing in DCIS? Yes, no, or in specific situation? So still people are in favor of no, but some yes is there. Okay, let's see. Good. So Sharna, we see that 23% is in favor of doing the HER2 test and 68% is in favor of not doing the test, and 9%, there's 2 out of 22 is in favor of, in special situation, they want to do it. So there is a mixed type of reaction. So the question to our today's local faculty, Dr. Mamun, will you do HER2 test?
Yes, sir. I will do HER2 test in case of some situation. If the pathology say the tumor is highly proliferative and the tumor volume is more than 3 centimeters, then I will advise or request for HER2 test. Only to know the HER2 status, though the anti-HER2 is not recommended.
So why you want to do it? If it is anti-HER2 is not recommended, what benefit you will get by doing HER2 test?
Only to know the HER2 status that may be helpful in the future.
For? Okay.
For if the tumor recurrence.
Okay. Okay. So Arman, do you do HER2 in DCIS? Yes or no?
Actually, no.
Okay.
No, because there is till now there is some weak or unclear evidences as a prognostic indicator of HER2 in case of DCIS, and actually it will not change the outline of management. So according to NCCN guideline, it is also not recommended to do HER2 testing in DCIS.
So first answer is you don't do it. Number 2 is you don't find a strong evidence in favor of prognostic role, and you don't find a reason to use anti-HER2 therapy. And last, our best weapon, NCCN guideline says, so we don't do it. Great. Farid, is there any situation in your center you use HER2 testing in DCIS?
No.
Okay, answer is no. John?
No. No.
Oh, okay, good. So let's see what I have in my box. So This is a paper published in British Journal of Cancer. I intentionally brought out this British paper because in 2019, they have found that they could find some relationship of HER2 positivity and aggressiveness, a poor prognostic picture, almost similar to invasive. But the problem is the long-awaited NSCPP 43. Last year when we were discussing, we said we're waiting for the result, but this paper failed to show any benefit of trastuzumab and radiotherapy. Objective response of 36% reduction of invasive conversion to invasive rate. So that's why they are still not recommending using HER2 testing or any anti-HER2 therapy. And the other paper also of neoadjuvant setup also failed to show any survival, if clinical benefit. So in nutshell, we can say that till now, guideline is not recommending doing HER2 testing. So better we should not do. Yes, it may give some prognostic idea, but it is not going to change our practice. So till now, guideline is not recommending, but you have the freedom to do. But if you want to talk about the guideline, it is not in favor. So it is a ER positive case. The same case is there. Now we are coming to surgeon's domain. I'm very happy that Dr. Zakirullah joined. Zakir bhai, thank you for joining. So next question, Sharna. I'm very sorry that today's question is so simple and so funny, but we want to know the ideas, what we think. Majority, there are some surgeons in the audience. So please try to answer, surgeon, non-surgeon. What do you recommend if a non-surgeon, that for DCIS, will you recommend BCS, mastectomy, BCS with axillary dissection, mastectomy axillary dissection, BCS with SNB, mastectomy SNB? I again repeat, there is no absolute correct answer. You can justify your answer by doing what you do. So let's see. So we have 19 respondents. 6 out of 19 was in favor of only BCIS. 2 out of 19 is in favor of mastectomy only. 1 out of 19 is mastectomy with axillary dissection. And 10 out of 19, 53% is in favor of SNB. So as our local faculties are not surgeons, I straightway go to Purit. So what is your practice in DCIS?
Well, for a lump of its 3 centimeter size, I think simply a breast conserving surgery, wide local excision would be enough. I would not recommend any axillary staging because technically DCIs do not metastasize to lymph nodes unless there is a hidden focus of invasion elsewhere in the breast. It all depends on extensity of the DCIs. If there's a huge area of microcalcification that would require a mastectomy, then obviously we need to do upfront. At the same time, we need to do axillary SNB only. And we don't even do an OSNA for these sort of cases. And the patient is young and fit and well. With that surgical option, we would recommend immediate breast reconstruction based on patient's choice and planning. So that option, I didn't see it. So definitely BCS with axillary dissection, the answer is no. BCS with SNB, answer should be no with this sort of scenario. But I've said already what I need to say. Thank you.
Arman.
Yes.
So forget about this patient, not this scenario. You have a DCIS patient in your chamber. You are expecting your surgeon colleagues to help you. What do you expect from him? Only BCS with SNB, mastectomy, or mastectomy axillary? What will be your expectation or what will be your discussion?
Okay. So it depends on the disease status. If it is widespread, disseminated widespread disease like in breast, 2 or more quadrant is involved with DCIS, then the mastectomy is required actually. And when there is requirements of mastectomy as well as high-grade tumor or larger tumor size, in that situation, we have to do the sentinel lymph node biopsy. And otherwise, we can go for breast conservative surgery only.
John, I know you are not a surgeon, but still, are you a believer of mastectomy in any situation of DCIS?
If they've got a very small breast and they've got a big lump of DCIS, yes.
Okay.
So depends what the cosmesis effect is going to be, I'd say.
Okay. So you are in favor of mastectomy when there's a very small breast, a big lesion. BCS will not give a real cosmesis. So Nafisa, please put the question in the chat box. We are not going to allow anybody to talk. So the answer is BCS and mastectomy because there is no survival benefit. It's patient's preference, and definitely SNB is a standard of care. And what NCCN is telling that lumpectomy without lymph node surgery and total mastectomy without the sentinel biopsy, plastic reconstruction, what Farid was telling. And in the short note, they were telling that they have discouraged the axillary node dissection. That is very important. If you feel to know about the axilla, we are allowed to look into the SNB, but not to go for axillary dissection. That is the main message that we can give here. And ESCO is recommending that SNB is an appropriate thing for early stage. No need of axillary node dissection. And this is an interesting meta-analysis published in 2011 of 7,350 patients of DCIS in 52 studies. And this paper was in strongly favor of doing SNB because they found that after surgery, 1 out of every 4 DCIS was having hidden invasive component. So they are telling that considering the size, grade, mammographic features, and palpability, we should be strongly thinking of SNB. So we can conclude that BCS is a standard choice if cosmesis is not a problem. This is not giving you a less mortality survival benefit. Axillary dissection is no, SNB where we feel. And mastectomy if the patient want. So now Arman, it's your call. BCS is done and SNB was also done. Even Farid was not in favor of this case, but this patient has done SNB and came out negative. So will you give her radiotherapy?
Definitely, I will go for radiotherapy.
Why? The patient is asking why you want to spend the money.
Okay.
What you are expecting by giving radiotherapy?
Okay. Actually, that's in this situation after breast conservative surgery, the radiotherapy is given actually to eradicate any residual microscopic disease to prevent the ipsilateral breast tumor recurrence.
So you are in favor of giving radiotherapy?
Yes.
Fine. So let's see what is the poll. We heard from Arman. Let us see whether we are convinced by Arman's statement or we move from each other. Whether it gives OS benefit, it gave, sorry, not DFS actually, or PFS, with recurrence risk reduction, or none of the above.
What was the margin, Kamal? It didn't mention what the margins were.
It was 5 millimeter.
Okay.
So we have 17 out of 50. We have only 17s are joining always. I see that the magic number 17 is there. I don't know what is the. So 94% was in favor of risk reduction and 6% was that 1 out of 17 was none of above. But nobody was in favor of showing this any survival benefit. So that was the main catch that, well, if you look at the NACBP 17 paper, which was the paper that tried with adjuvant radiotherapy, and others were URTC 105, 853 UKCCR and SWE DCIS, all have shown that it has reduced the recurrence rate of ipsilateral invasive recurrence and non-invasive recurrence, both around by 50%, but could not show any OS benefit. I'm sure, John, you want to say something about the margin and the risk factor. John, any comment on radiotherapy, DCIS? Will you give all?
I won't give all. So there are patients who have low risk tumors where the risk of toxicity from radiotherapy, I would say, outweighs the benefit. So I'd say in our MDT, we still use the Van Noys score. I know it's not exactly based on thousands of patients, but for this patient, they were 40. So they get 2 for their age. They score 2 points for their 5 mil margin. They'd get 1 point for the size of the tumor and then they get 3 points for the grade. So they get a Van Noy score of 8, and normally we'd use 7 or above to advocate for adjuvant radiotherapy.
So if I understand well, that you are not a believer of giving radiotherapy to all, you want to score the patient by high risk and low risk and segregate. So now I come to Farid. You are a surgeon, DCIS surgery is done, DCS. Are you concerned about the margin? 1 millimeter, 2 millimeter margin on ink? I mean, are you a very micromanager of?
Well, in UK Association of Breast Surgeons, we had a consensus meeting a few years back about the margin, and the agreement was 1 millimeter minimum.
What
The reality, the more, yes, and invasive. The more the margin, the better. So that reduces the risk of recurrence. So we always aim to get a bigger margin. But if it is a millimeter, surgical treatment is complete. Now, because this lady, she's got a high grade DCIS, and then she's quite young, she's 40, I believe. So based on these two criteria and with Van Noy's, I think she's probably scoring about 6 or 7. I think John will be able to calculate it better, but I think she will probably score 7 at least. And hence, in MDT, I would recommend, from my perspective, that she should be offered radiotherapy.
So John, what is your practice regarding only the margin? If it is a 1, 2, 3 millimeter, I mean, is it going to change your decision about adjuvant radiotherapy?
So again, in our practice, if they're young, so if they're under 50, we also give a boost. But if they have a close margin and there's less than a millimeter and they can't go back to surgery, so for instance, if it's deep margin or it's the anterior margin, we'll boost them again. But if they've got under a millimeter, we'll ask our surgical colleagues to re-excise their margin. Again, margins are key, so for local recurrence.
So there are some factors like age, grade of the tumor, margin status is also important. So we know that it is not giving a benefit of survival yet proven, but it is giving 50% reduction of the recurrence. So there is a strong role, but again, we can stratify the risk. These are the folks and a trial that has observed the effect of radiotherapy. And if mastectomy is done, we can skip the radiotherapy, or in low risk DCIS as per ECOG 5194 or RTOG 9804, grade 1, 2, if the size is less than 2.5 or margin is more than 3 millimeter. This was as per this study that they said that you can skip the radiotherapy.
All right.
Kamal,
yes, please.
can I ask?
Arman.
If they've had a mastectomy and their deep margin is less than 1 millimeter, so mastectomy, deep margin less than a millimeter, do you ever discuss adjuvant chest wall radiotherapy with your patients?
That is one interesting question I was trying to keep for you, John. That is one of the last question I kept for you. Okay, so Arman, you wanted to say something?
Yeah, so I just want to share that in RTOZ 9804, in their 7 years follow-up with RT and without RT, they found that with RT it was 0.9% local recurrence, and without RT it was 6.7%. But even in low risk group categorical patients, they agreed that without RT the local recurrence is low, but they found that with the addition of radiotherapy in that situation also the local recurrence was significantly decreases. And regarding the survival issues, yes, most of the papers are on the local recurrence decrease reduction, and about 50 to 52% reduction of the local recurrence. But in a recent population-based study, they found that with the addition of whole breast radiotherapy in case of higher risk disease like high grade or the younger age patients or a larger tumor size, in that situation the local recurrence is statistically the whole breast radiotherapy give statistically significant survival benefit. I can't mention the name of the trial, but it's a recent population-based study. Thank you.
Thank you, Arman. So I come back to you again. So the patient, we agree to give radiotherapy, 40 gray 15 fraction. Will you give boost to her? I accept that the data gives survival. It's a good thing. It is bread and butter for the radiation oncologist to give radiation after the surgery. And guideline is also recommending. Will you give boost?
Yes, I will go for boost.
Why?
We know that from invasive breast cancer, that is, the boost is given to decrease the ipsilateral breast tumor recurrence, to reduce the ipsilateral breast tumor recurrence. In case of DCIS, there was a 9 years follow-up trial, and they found that lumpectomy done, whole breast radiotherapy given, and randomized to either boost or no boost. And they found that the local recurrence in reduction in 5 year is about 97% with the boost, and without boost it is 96%. And 10 years follow-up, the decrease of local recurrence is 94% with boost, and without boost 92%. And 15 years follow-up, it was 91% versus 88%. Though numerically it is not so different scenario, like the number is not, the difference is not so large, but they comment that with the boost radiotherapy, it significantly decreases the ipsilateral breast tumor recurrence in the total cohort. So I will go for boost for that
What
region.
fractionation?
Fractionation, if it is a hypofractionated breast radiotherapy, then the fractionation is different, and if it is in conventional, then
What do you use? What you practice?
I practice for whole breast radiotherapy with hypofractionated regime, followed by 5 fraction boost.
5 fraction boost. Okay, so as you mentioned that we extrapolate from the Lyon trial that boost, and if you look at the URTC trial that was published in AGM, but the NACBB 24, they have used the boost only for positive margin. So again, the boost is giving us reduction of recurrence, both in invasive and also in DCIS. So the role of boost is always there, but again, it is reducing the recurrence. And in NCCN, what they are telling that lumpectomy, when we give whole breast radiotherapy with or without boost to the tumor bed, and total mastectomy is totally different. And they are telling that in case of factors determine local recurrence is palpable mass, larger size, higher grade, closer involved margin, age less than 50. So these are the risk factors they are telling. And they are also they are telling that the APBI is also could be another option. So John, any comment on boost?
So we've adopted 26 in 5 as, you know, we've gone fast forward with our whole breast radiotherapy for DCIS as well. And then we normally give 10 in 5 boost. And again, given her young age, I would boost her as she's under 50. So
is there any situation, John, lumpectomy done, keep on follow-up?
So
you do, I mean, low score, you just put on follow-up after lumpectomy, very happy, very low score.
yeah, so if they've got grade 1 centimeter, 10 mil margin, then I just put them on observation.
Yeah. So this RTOG 984 and 5194 study, they were telling that with this 1 centimeter, less than 1 centimeter, grade 1, 2, and adequate margin, we can put the patient on observation. So the patient was given whole breast radiotherapy, 40 gray 15 fraction, boost was 10 gray 5 fraction, and tamoxifen 5 years offered. So now, John, the question you asked for, you see, I have kept it for you. In post-mastectomy chest wall radiotherapy indicated this is very close, less than 1 millimeter of positive margin. Will you give radiotherapy?
So yeah, I do see patients and I will discuss post-op radiotherapy with them. So there are case reports where it shows that it can reduce local recurrence under these circumstances. So I would. Yeah.
So the recent two retrospective papers that I have found, both is in Red Journal, they were telling that mastectomy is quite low recurrence rate, and both of them said we can practice it, but they were not in favor, but these two are retrospective papers. So this cannot be a conclusion. So almost I am there. So if we recap from the beginning, please correct me, John and Farid, that for the imaging, we can start with ultrasonogram and mammogram bilateral, and in select case, we will go for MRI. And then for hormone receptor testing, if we know that it is a DCIS, we don't need to do anything more than ER because there is adequate data not to do PR. And HER2 still not a recommendation. And for surgery, BCS is a fantastic option for them. But if the patient wants, we can go for mastectomy, SNB, as we discussed in some situation, but total no for axillary dissection. But I think there are some situations where we find a DCIS in the breast and we find a node in the axilla, then our life becomes difficult. And then we end up going for axillary intervention. John, you wanted to say something?
So I think the oncology club meeting in 2017 was in the military golf club, wasn't it?
Yeah.
And so I remember one of the posters that won, that Zaka may remember, that we scored, was about a lady who'd had an amputation of her left arm because of metastatic DCIS. Do you remember that? She had a huge fungating deposit of DCIS. And I have to say,
you were the judge for the poster session, I remember.
That's right.
Okay.
And it still sticks with me today. I couldn't quite get over it. There was the autopsy pictures of the specimen, quite incredible. So
okay, so that is sometimes happens, John. We are facing some situation at end of the day when we bring out, we found there are some invasive component which we miss. It missed many parts of the world, but here we have these challenges much more. We are struggling with many things for the low resources. So after that, we are not in favor of doing any HER2 testing because it may give some prognostic value. Farid, you want to say something? Yes, please.
I think I'm not sure whether we are missing something else.
Yeah, please.
I mean, my experience, what I've been noticing here, this part of the world is some are offering even chemotherapy for DCIs. And it would be nice if you could have raised that topics today so that we get it quite clear.
Okay, Farid. Mahmoud, you are a medical oncologist. Under any circumstances of DCIS patient, is there any scenario where you will give chemotherapy 2 cycles, 4 cycles, or 8 cycles?
As far as I know, sir, in case of DCIS, chemotherapy is not recommended.
So as far as you know, have you ever practiced?
No chemotherapy I recommend.
You have never practiced. Have you seen?
No, sir.
Okay. So Farid, thanks for correcting. This session was a very last moment preparation. Definitely, I should have brought this question. It is a burning issue. Unfortunately, sometimes we see some patients are treated by chemotherapy. Unfortunately, I will rather say, maybe, in our region, there are some believers of over-treatment because they think that the pathology that we are seeing may not be giving adequate. Maybe something is hidden. So better to be safe. But the answer is ethically, if we accept a pathology report, we need to accept totally. We cannot take it partly. So either if we don't believe, we need to review it. Pathological review, was Mamun was trying to say at the beginning, is a standard recommendation of all guideline when it is a DCIS. Why? Because we should not miss any invasive component. That's the reason. But once we are sure that it's a pure DCIS, there is no proven benefit or rationale of using, I would not say benefit, there is no rationale of using any chemotherapy in DCIS. Thanks for raising the question. And it's a very valid, very important point I think we were missing. So there is no role of chemotherapy, either any setup, except palliative, as John was telling, that finally we missed something, patient ended up in a metastatic, and then that is a different scenario. So coming back to HER2, there is no role. And then radiotherapy, yes, if it is mastectomy, no, but in a special situation, what John was telling, there is a debate about margin positive or less than 1 millimeter. John.
I think it's also interesting when you've got patients with mixed invasive and DCIS, and for instance, they have neoadjuvant chemotherapy. And then when you do your surgical resection, you find a complete pathological response, but your DCIS is still sitting there. So it again shows this sort of doesn't work. So
yeah, John, PCR, I intentionally didn't bring. There is an interesting paper on PCR by Herceptin, and they found that even they are getting some standard PCR, but that was not giving a survival benefit. So, the people are trying to bring up NSCT, but till now, not NSCT, neoadjuvant Herceptin, but still they fail. Yes, that is interesting that when we give and finally it end up like that. So regarding radiotherapy, whole breast, we can give 15-25 or 14-15, whatever is practice, both is fair. And people like John, they have moved to fast forward. We are trying to adapt. We have not completely adapted. Some of our centers are trying to slowly move into it. I know Mustafa Aziz Shuman is one of them. And then regarding the radiotherapy, there is no need of any auxiliary management because surgery we omitted. So there is no role of radiotherapy to any RNI there. So only breast. And if it is chest, it is only chest wall. And again, there is a debate. Both is correct regarding boost, like whole breast, like invasive. Boost can be practiced in select cases. Again, it reduces the chance of recurrence. So then we have discussed this. Now I have an interesting paper that I pulled up. It was published in JCO in 2020. De-escalation of locoregional therapy in low-risk disease of DCIS and early-stage invasive cancer. So they have discussed 4 things in broad. Omission of radiation therapy after breast conserving surgery for DCIS, omission of surgery for low-risk DCIS. Another 2 is for early stage, but it also covered DCIS, breast conserving surgery without radiation treatment for early stage, selected de-escalation of auxiliary surgery. So I think very important, interesting is first 2. So I will ask first to respond from omission of radiation treatment after breast conservation surgery for DCIS. John.
Yeah, I think we touched on earlier. I do believe that you can take selected patients to avoid radiotherapy. The other thing that we don't use, which again, I'm not sure of the data, is oncotype DCIS in terms of looking at the genomics of DCIS and using a oncotype score for DCIS post-surgery radiotherapy. So again, it hasn't been adopted in the UK yet, so the jury's still out.
But there is a recommendation that oncotype DS is recommending for DCIS also. They are recommending that can stratify the risk group. Okay, we already touched upon that, John, but as this paper was quite interesting and very recent one, because now, in many part of the body, we are trying to de-escalate the treatment. So what about Farid, where we can avoid surgery? Any thought in DCIS?
Yeah, you can. There is a trial ongoing. I think it just concluded. It's just finished. Low-risk DCIS, low-risk trial. Similar trial is running in Europe and also in USA, like Comet trial, LOR, these sort of various names. But low-risk is it for UK. And we were recruiting patients as well, where it was suggested that any size of low-grade DCIs or intermediate grade DCIs, and if the patient agrees for getting into the trial, so they put into 2 arms. One is surgery and the other one is follow-up. So there is a possibility in future, who knows, in a few years down the line, for low-grade DCIs, particularly irrespective of the size, we probably would not be opt for surgery. We just follow them up with annual mammograms.
But don't you think that still that meta-analysis is telling 1 out of 4 DCIs is having invasive component? So if you start doing no surgery, then maybe we will be missing that invasive component, because without
that
surgery,
meta-analysis, you would not find many low-grade DCIs cases, to be honest. So the question is about low-grade DCIs and few intermediate-grade DCIs, and it is believed that trial will give that answer, the outcome that once is published. It is believed that the low-risk DCIs probably never turn into any invasive focus at all. So that's where it's coming from. So we will have to wait for the trial outcome.
Thank you for it. So let me go to the chat box. Shuman was telling NSB 35 shows anastrozole better than TAM in postmenopausal. Ishraq Ben Abdullah, who joined, thank you for joining. Is there an indication of sentinel node biopsy for DCIS if the size is large? I think we have already touched upon it. Alina Fisa, when SNB needed in DCIS, already we answered it. If any suspicion of invasion are present, LAM SNB can be done. Great. Is there any OS if RT? Mustafa Shuman already discussed. Arman was telling there is a paper, but I don't have the paper in my record, but maybe we can discuss it next week. Is there any indication of giving hormone therapy for 10 years in DCIS? Tania Froze, I think no, till now, no such data. Mamun said 5 years, yeah, the Mamun. Asma Siddika, 9 centimeter DCIS, grade 2, 38 years old lady underwent breast conservation and radiotherapy. Patient is on hormone therapy. What is your comment regarding the size and follow-up? So the 9 centimeter, if it is a real DCIS after the surgery, for it, any comment? 9 centimeter DCIS, grade 2, 38 years.
I think Mike Dixon has done a lot of work. There's the Edinburgh chap, the Professor Mike Dixon has done a lot of work on this DCIS thing. And one of his presentation, he was mentioning that it's irrespective of the size, it doesn't matter. If there is a large volume breast and he had taken out a 9 centimeter DCIS, if you got a good clear margin, and that was kind of like, it still gives a decent cosmesis and patient gets radiotherapy, that's absolutely fine. But again, I believe that this deserves some sort of debate and discussion in MDT, depending on individualized case. So I wouldn't go for like one size fits all planning. If it's an elderly lady, who's got a very large breast and patient had a wide local excision or a wide-guided wide local excision for DCIS, and it turned out to be a lot bigger than what was thought on the images, but it's still clear margin, we would not normally go back.
Okay, for it, thank you. So Shuman was telling, are we not over-treating for DCIS patient? Is there a role of oncotype DX? OncoDX, yes. OncoDX, there is a recommendation, but as John said, they are not using it. So Alina, if we say in our country, this is a mastectomy, clearance, chemotherapy, usual practice. Not usual. We see some cases. We should not say usual, but we see some cases, unfortunate cases. As I said, the reason behind is there are some believers of over-treating. Kaji Abdullah Mamun, if ERP are negative, should you use tamoxifen? The answer is no. Abdullah Mamun, I think no. Yeah, Dr. Shuman, for DCIS, can you use fast forward trial? Shuman, usually fast forward trial, not including the DCIS for a study endpoint, but definitely we can. I have tried one. John said they are also using. For low grade DCIS, reporting quality should be improved. Yes, we agree. So this is what we were there.
Kamal Bhai, can I ask a question?
Yes,
Sorry to
please.
interrupt. So if the histopathology report has come out as DCIS with foci of microinvasion, then how should we proceed?
So the moment you have a microinvasion, this is the microinvasion, foci or big or loss, whatever it is, then you need to treat it as an invasive. Then again, it is again the low risk invasive like that. And say, for example, surgery, you need to do the SNB, not axillary dissection. For chemotherapy, you can use, but you need to know if it is very small. And now you look at the age, comorbidity, and you can decide the risk of using the chemotherapy. So these are the factors. The answer is, if there is an invasive component, you need to treat as invasive. But again, you need to see how much invasive component is there. It is 2 millimeter, or the age is 70, having so comorbid. Definitely, we are not going to give her chemotherapy. Last year in our
We should talk to the histopathologist regarding the size of microinvasion.
Of course.
Yeah. So if it is like 1 mm or 2 mm, should we go like invasive treatment, like invasive cancer, or like DCIS?
We think like invasive, but we don't treat it as a DCIS, but we think like invasive, but we understand it's a very small tumor. It is invasive, but we need to discuss with the patient, but we should not go for 8-cycle chemotherapy and everything. We should understand it's a very small component, and then we look at the age and other factors, comorbidity, then we can discuss how much benefit we can give. The question is the chemotherapy, shall we give or not? Normally,
Kamal bhai,
yes,
am I allowed to say anything?
Yes, please.
Yes.
Please.
So regarding these issues, DCIS with microinvasion, there is a study. They have tried with derazumab chemotherapy, but it failed to produce any benefit. So still, this microinvasion issue is in
debatable issue.
But
I would like to hear some comment from John, because I have a patient with this type of thing with a microinvasion, which is very small, 1 mm.
John.
I think the trickiest is if it was grade 3 triple negative. That's really going to be the only one that's going to make you feel nervous about how you manage it. If it's ER/PR positive 1 to 2 millimeters, then they're not really going to benefit from adjuvant chemotherapy. You're still going to do radiotherapy and endocrine treatment, so I don't think it would really matter.
So,
and John, if it is multiple foci, then we should calculate all the foci all together to have a final size. Is it okay?
So we wouldn't normally. It would be T1M, wouldn't it? So multifocal 1 to 2 millimeters. But again, it depends on other factors. If they're very young, then again, I'd just have a discussion with them about the risk and benefit of therapy. If they've got 30 1 to 2 millimeter small amounts of disease in the breast, then you're probably going to feel more comfortable discussing chemotherapy with them. So you'd have to base it on the history. So, and again, that we've got this group set up, haven't we, for discussing such interesting cases, these ones that are quite unusual, I would say.
Farid, you have to make some comment.
Yeah, thank you. In fact, even if it is a multifocal, we do not recommend that you add them up. All you need to do is to find out the largest foci, and that would be the size. And this is what is currently practiced at the moment. And multifocality is not an indication for radiotherapy. Again, you would be guided by the high size of the foci of the cancer. Obviously, if there is a nodal positivity, that changes the whole perspective. That's in a different scenario. So hopefully that
thank you, Farid. That was the discussion that when there is a micro-invasion, invasive foci present, we no more can say it is a DCIS. But again, we need to understand the low-risk invasive disease. We are not giving chemo to all. We are not taking it such seriously. Sometimes we are giving surgery and radiotherapy. So this is like that. And another thing is what Farid said last. That was the most challenging thing, I think, what added by John. If there is a node and if it is a TNBC, these two things may make our life miserable and it will be challenging to take a decision. So I'm almost at the end of the time and we are almost at the end of the discussion. So there is a question from Banuapa. Can you please ask or follow how many frequent mammogram and MRI should be done in case of breast cancer surgery in DCIS? Either of you can answer, Farid or John, anybody.
Annually. At the end of the reverse surgery. Mammography. That's what we normally do.
Yeah, I'm not sure about the MRI. As John just rightly said, just annual mammographic surveillance. Depending on the age of the patient is young, 40, then she would need it for 10 years until he's 50, then she gets into a screening like 2 to 3 early mammogram afterwards. But if patient is postmenopausal over 50, then just 5 years, annual mammogram.
Thank you. So we are almost at the end. We have a foreign, participants, not the faculty, Ishraq Ben Abdullah. Thanks for joining. Would you like to make a quick comment on the session that you joined? You are from Tunisia, if I am not wrong. Ishraq, are you there? She is a medical oncology resident. Okay, I think she is not available. And I have another senior surgeon joined with us, Dr. Khandakar Azad from Chittagong. Thanks for joining with us. Azad Bhai, any quick comment? Dr. Azad. Okay, so I think we are almost at the end, and next week you will be having a similar session on neoadjuvant chemotherapy in breast cancer. To make life easy, next week the moderation will be done by Mustafa Aziz Shumon, and we are expecting Dr. Zakirullah and John Conibier. If Zakir Bhai cannot make, Farid will be there. So 2 British, 2 Bangladeshi combination will be there again, and hopefully you will all join with us. And our academic partner for this session is Roche. Thanks to Roche and thanks to all. And next week, we are going to give you the result of the best respondent of this 5-poll question. And this design will continue. And hopefully next week, we will have more responded for the question answer. So with these few words, I want to thank my four faculties, two from home and two from overseas. Actually, one from overseas, one half overseas and half home, and two from home, for the brilliant discussion, and all the participants. They were so active. I'm so happy. And thanks to our president. This idea came from our president that make a poll, let everybody join in the decision making so that everybody feel a part of it rather than boring listening. Thanks, sir, for your brilliant idea, and it worked on the first day. You see that participants went up to 50. So thank you, sir. And would you please like to conclude the session?
Thank you, Kamal. Exactly, I felt our previous sessions, our participants are not taking a part exactly. So I wanted to make it a bit participatory. I think this we shall have to continue this for some sessions, and again we shall have to take polls from opinions from the participants whether that's accepting this well or not. Thank you all very much. It was
Thank
nice
you, sir.
session.
Thank you, sir. I'm seeing Salma there. Thanks, Salma, for joining. I know you people are so busy, but people like you, when you join, it gives us aspiration to go forward, because when you join, your student follow you. So this is how things work, and we are trying to go forward. And hopefully next week we will be meeting each other, sharing our experiences, talking about neoadjuvant chemotherapy in breast cancer. Till then, stay safe and goodbye, everybody. Allah Hafiz.